Why don't we just take a seat here? And you know what? I'll let the panelists introduce themselves. So starting with you, Dr. Purnell, what's your background and what was your journey to leading data science innovations at the VA?
Well, good morning, everybody. I'll check my mic as well. You can all hear me? Oh, excellent. I'm a psychologist by training. I spent the first decade of my career at the VA being a clinician. I found my way into data science because I saw the need for better information at the point of care. I saw clinicians and care teams struggling to get the information that they needed to make adequate decisions at the point of care, as well as understanding the impact of quality improvement initiatives that they were trying to engage in to know whether there had been an impact. So I found myself following down this massive rabbit hole, and now surprisingly finding myself leading data and analytics innovation at the VA with many other partners.
The VA is really good at rewarding inquisitive and curious people by giving them lots of work.
That is some truth. Some truth.
Dr. Caban, on top of being a principal researcher, you actively teach data science at a couple different colleges. What experience brought you to lead at Walter Reed?
So thank you so much for the opportunity to be here. And I have to say, I'm speaking here on my behalf, not on behalf of the DoD or the federal government. So all I'm saying is my opinion. So what brought me to the DoD? I have been in the DoD leading a lot of the data science efforts for 11 and a half years. So I used to be at NIH, but first, the mission within the DoD. Second, the amount of data that we have. The amount of data is because we have been talking so much about longitudinal data, but in the DoD side, for many, many, many years, we have patients since they are born, all the way until they decide to join the military, all the way to when they retire and go to the VA. So that massive amount of information that we have in healthcare, brought me to the DoD. And what has happened? So for the last 11 and a half years, we started building data warehouses. First we started with some data warehouses, then 2013, 14, we said, hey, we need to virtualize data, a lot of the data. So we started doing a lot of data virtualization work. And now that has moved into other offices. I transitioned that, and now a lot of the data, 9.6 million patients and all of the data, it has been standardized and it's accessible for research. So if I put my researcher hat, we're using that data every single day to understand outcomes, understand the treatment that is benefiting the patients, and so on. So that has been a little bit of my journey in the DoD.
And your clinical assessment management portal, or we'll just call that CAMP, it's rolled out across, I think, over 100 facilities. What can we expect next from that program, and how are you using those clinical data warehouses?
So that tool, specific tool, we call it CAMP. It's an application that we build to understand outcomes. Because for those of you that are in the military and understand the Defense Health Agency, you can Google this. The number one priority is great outcomes. If you're in a healthcare organization, you want great outcomes in your patients. So how do we collect outcomes? There's a lot of different ways to measure outcomes. But one of the most significant methods to collect outcomes measures is by patient self-reports. When we go to the doctor, they ask us to fill out some in an iPad or in a paper form. How are you doing? What is your pain? Where is your pain? What, can you drink or not? You're a smoker. So those questionnaires are critical to understand outcomes. So what we did, we designed for many years this tool to collect outcomes. So right now we have over 1,000 standardized patient reports that we support the mental health clinics, TBI clinics, amputee clinics, pain clinics, ortho clinics, and many others. So then they have been adopting those tools to say, okay, the patient come here because an amputation, let's say. Okay, let's start collecting outcomes measures so we understand where the patient will be or where the patient is 6 months later, 9 months later, a year later, 5 years later. So right now we have As you mentioned, over 100 plus clinics are using these tools. We have millions of what is called PROs, patient-reported outcomes, that we're using, supporting different what is called clinical communities, so they understand the outcomes within their patients. What is next within that tool? The next important for both DoD and VA is to think about how the capabilities provided by Cerner, in the DoD we call it MHS Genesis, the tools that we have, how they will integrate. And that's what is next. Start using FHIR, and on top of FHIR, Smart on FHIR apps to take those PROs, patient-reported outcomes, to take those existing millions of outcomes that we have that shows the patient's trend. How is their pain over time? Integrated with the EHR at the point of care. So that's what is next. That will be the main focus for the next year.
I assume those outcomes will be fairly useful for training additional models.
Correct.
As well.
Absolutely.
Okay. So Amanda, I feel compelled to ask about Mission Daybreak, which just wrapped phase 2 last week. Can you give everyone here a brief synopsis of that effort and the potential impact for veteran care?
I feel really fortunate to have been part of the hundreds of people who have participated in developing, coordinating, and organizing the Mission Daybreak effort. It's an incredible partnership across various areas of the VA to catalyze towards preventing suicide for veterans. And so we knew that with a complex, difficult challenge like suicide prevention, we needed as many friends as we could gather. What I'm incredibly enthusiastic about with this particular challenge is that we had 1,300 separate submissions as part of the challenge. We had 450 volunteer reviewers looking carefully at each and every one of those submissions, painstakingly figuring out which 30 would move on to phase 2, and then tailored support, engagement, and support of these 30 teams over the course of the time from late August now through to demo day, which occurred last Friday. It was so incredibly inspiring to see the enthusiasm of very small entities, like single individuals who wanted to be part of this solution, as well as larger entities, nonprofits, veteran service organizations who want to work together. We have an awareness here that suicide, being the complex challenge that it is, there is no one thing that is going to move the needle in the way that we need it to, but it's by bringing all of these folks together, bringing them literally together in a room, but building a community of solvers who will continue to work together after this challenge is always our goal, and that we will continue to learn and grow together. So I've just been incredibly enthusiastic about this particular challenge.
Yeah, one of the unique dimensions of Daybreak is the focus on the veteran's user experience. This is a subject that doesn't come up enough, in my opinion. Can you help our audience understand the intersection of user-centered design and data science and AI/ML?
Yeah, I'll do my best.
Okay.
So I think where I come in, and I think the unique capability of what we can offer here is, I said I was a psychologist by training, I'm a clinician by training. My background is actually in qualitative research and discovery and design. And so I love the marriage of people like me with wonderful, talented people like Dr. Caban who have data science expertise. If we bring together what is the experience of the veteran as they engage with or do not engage with care systems, what's the context of their life, what is their neighborhood like, what are their social support systems, what kinds of technologies do they engage with or not engage with, and understanding what they're already drawn to and what is the context of their experience, in understanding how we might present better ways of doing things. So rather than going from the technology first, we start with the experience first and do the deep understanding of what is that context of that person's life, and then see, oh, I see these areas of gaps of information, or maybe if we took this information together, did some analysis and pulled it together in a particularly interesting way, it would help to leverage an insight that would help change the inflection from going left to going right and really improve the care pathway for that veteran. So it's the marriage of those two that I think is really compelling.
So similar question, Jesus, for your TBI programs and the training that you're doing for mental health AI models, how have you incorporated patient and provider input into that training, this in similar vein to what Dr. Purnell is talking to?
Absolutely. So, TBI, traumatic brain injury, also known as the mild TBI, also known as concussion, it is, happening every single day, right? Training, deployments, and so on. So the first thing that to be able to apply machine learning models, predictive models, forecasting models to it was, do we have data, right? So in 2013 and so on, we were able to stand up, we were asked to stand up the DoD TBI patient registry. So every single patient that have had since 1999 until today that have had a concussion is in our registry as active duty. And all the medical records has been standardized and is in our registry. So millions of labs, millions of medications, clinical notes, and so on. So then once we had that as of today has probably about 510,000 patients, active duty patients, and all the medical records and so on. So we say, okay, now we need to start creating models to understand, okay, the likelihood of developing mental health conditions. How many of them develop mental health conditions after having a concussion? Does it take 6 months? Does it take a year? When do they start developing those mental health conditions? So I had the opportunity, also my team, we're part of what is called the Defense Intrepid Network for TBI and Brain Health. So we have facilities at Walter Reed, for Belvoir, and 13 other sites. So those sites that I go and visit as well, the providers, we go and sit down and say, hey, PTSD, what do you think are the key features that we need to add into potential models that we are building? So then they, mostly psychologists, psychiatrists, neurologists, speech language pathologists, and so on, they start providing the clinical perspective. Okay, it's important to look at this variable. Hey, in the labs, don't worry about this because that will add noise to your models. In your personality test assessment and so on, hey, use this instead of this other thing. So the input from the providers, I would say it is critical to be able to build any of what we have built, predictive models for mental health after having a concussion.
So in addition to the input from the provider, the patient, you mentioned the importance of data in that. It seemed like the first thing you actually approached. Data science without good data is not much of a science. So what are some of the successful data integrity initiatives that have helped these programs advance?
So I would say, first, definitions. What is a TBI? What is a concussion? What is anxiety? What is MDD, a major depression disorder? Interesting enough, even among providers, the way they diagnose someone, hey, you have this, sometimes it's not the same.
Yeah.
So being able to meet, we run some what is called work groups for different communities. And I say, how do you define PTSD? How do you define depression and so on? I would say that has been, having standardized definitions has been the single most important thing that we have been able to do with the help of providers to be able to input good data to our models. Any
programs at VA that are, really taking advantage of are moving the needle on data integrity, and what kind of impacts are you seeing there?
Similar to what Dr. Caban is saying, there's a lot of conversations between humans about what data means. So you have to look at various data sources and say, this data means this particular thing, this data means this other particular thing, as well as efforts to understand which sources of data do we trust, do we consider authoritative data sources, and how do we combine and make those authoritative data sources or products that are developed from those authoritative data sources readily available in a cataloged fashion. And so people coming together across many parts of the VA to agree, this is a source that we trust, this is the meaning of this data, and we're going to put it in a place where people can access that information.
So our audience probably doesn't know too much about this, so we should talk about it, I think. Hidden in your statement is a lot of effort around using synthetic data at the VA. What further innovations can we expect from synthetic data usage, and what about cross-agency collaboration?
Yeah. So, I talked about, like, within the VA, the need to really feel trust and confidence in the data. In addition, we need to be able to use the data meaningfully. And so one of the tools that we're looking at in order to liberate access meaningfully for solving problems is to develop high-quality artificial versions of the original data sets. So taking real data, running a machine learning model, generating an artificial data set that we can use to develop early alpha or beta stage tests of really compelling solutions without ever making the original data access. So using synthetic data was one of the tools as part of Mission Daybreak. So of those 30 teams, 19 of those teams made use of synthetic data as part of their solution. Some of the solutions for Mission Daybreak didn't have a data analytics component or wasn't necessary. But it allows us to meaningfully share data, both with academic partners, with industry partners, as well as intergovernmental partners, because there are solutions or there are problems that we need additional partners to solve. So speaking specifically to governmental collaboration, working with the NIH or working with FDA or working with the census, there are some solutions or some problem spaces that we can't solve with our data alone. If you think about the veteran journey, as Dr. Caban noted, the veteran is initially a service person or they don't become a veteran. So we have to understand that longitudinal experience as well as the ways in which veterans access care outside the VA or the context of their lives outside the VA. And so synthetic data is one of the technologies that we're making use of to make it easier to collaborate with other partners to solve problems.
And what do you see, outside of that collaboration, what do you see AI's impact on the clinical experience? As AI becomes more widespread and actually used, what are you seeing today? What are the impacts? And then what are some of the impacts you're most excited about?
Where I see AI being adopted within the VA is in reducing administrative burden, those just pain points. So I like to say, because it's true, that there is no physician, clinician, psychologist who ever got into that field saying, what I really want to do is fill out a bunch of forms. And I want to search through piles and piles of data to find what I really need. So what clinicians and care teams are most readily adopting models for is reducing the administrative work of doing the clinical work so that they can spend the time doing what they really love, which is caring for and interacting with people and helping them to live their highest quality life. So where I see AI and ML and other technologies being adopted within the VA is making it easier for those clinicians and care teams to do the work that's meaningful and do less of the administrative work that they don't want to do.
Jesus, so pretty much the same question, but curious about your perspective on the impact of AI in theater. Can edge computing with AI actually change patient outcomes?
Absolutely, will change patient outcomes. But I would say that's one of the greatest areas for innovation in the DoD healthcare side. It is, what are we doing at the point of injury in theater? Mm-hmm. The reason being is that, we are here in a city and so on. If something happens, we are max 15 minutes away from a nice ER, right? A nice level 1 trauma center. When you're in the middle of nowhere, right, it will take a day It might take a day. We're seeing that in current wars, right? It takes a day to 2 days to just reach a hospital. So I would say there is a lot of opportunities out there for us to be able to go and say, how are we leveraging, devices at the point of injury, edge computing, to be able to help not the doctors at that level, are the corpsmen, the medics, to be able to, or the patient itself, to stay alive for a 24 hours, 36 hours until reaching a hospital. So I would say there is a lot of opportunities out there. Last night I was meeting with the PM and so on from JOMIS, the Joint Operational Medicine System. And they have a lot of nice devices that they're deploying to theater, right? The JOMIS folks. So as they were showing me the different tools and new software they have, I was asking that. It's like, but where is telling me, or telling the medic, say, hey, you should do this, because you have nice pictures to show gun wounds, what kind of injury, and so on. But I need a helper somewhere here saying, hey, based on all this data you're entering, this patient needs to have X done within the next 5 minutes to increase the likelihood of survival by 30%. Things like that, I was telling them last night. It's like, hey, this should be the future, this should be the direction that definitely JOMIS needs to be doing.
What, in the war in Ukraine, what is that teaching us about response to medical care? There was a lot of there's a lot of legacy and traditional thinking about medics and their role in the field. What has that war taught us?
But once again, I'm not speaking here on behalf of the DoD
I
or
understand.
anything like that. But in my opinion, personal opinion, I think it is that. Previous wars that a lot of you might be have been active during the past and so on, the DoD had complete power, air power. So meaning the medevac could be there immediately and medevac the patient right away. I think what we're seeing right now in other wars, like the one that you mentioned, is that's not the case, right? As, based on what I read, like you all online, it's taking the patient, put in a train, and then takes a day to 2 days to get to a hospital, right? Yeah. Unfortunately, when you don't have air superiority, I think those things will happen. Therefore, I think we need to be looking at those situations and saying, okay, how can edge computing, how my predictive models that I have, how all the clinical data that I can have there, the environment, the sensors, and so on, will help to keep this patient alive. So I think that's what we should be learning from these current wars.
Great. Thank you so much. That's our time. Thank you so much to the panel for your participation today. Really appreciate you coming out. And if anybody wants to talk to the panelists, they're around. I know Amanda has to go take a call, but she'll probably be out and about after that. So please don't flood her. As soon as she gets off the stage, she has to go somewhere. But later on today, you'll be around a little bit. So thank you, everybody, for listening. I hope this was informative and insightful.